Many of the things our teams in pathology and in imaging have been working on for years are really coming to an important nexus. So I want to specifically kind of outline that I'm going to dance the fine line between conflict of interest and my own activities today, and start off with some disclaimers first. I'm one of the most conflicted individuals in this discipline because I receive money from everyone, including the vendor community, in dramatic ways. That money is channeled to focus on two activities that are near and dear to my heart: the Association for Pathology Informatics, which is a national member organization, as well as our national meeting called Pathology Informatics, formerly known as APIII. I also have corporate-sponsored research agreements from companies whose products I'm going to talk about in the talk today, particularly Omnics. And I'm on the scientific and technical advisory boards of Omnics. I received sponsored research money to do clinical research and innovate in Omnics. I have licensing agreements with Omnics, and I also have some company royalties. So I'm about as conflicted at every level as you go. So whenever I say Omnics, you can turn your ears off if you choose and not pay attention at all to my conflicts of interest. But I will use some of their work in my talk today, and hopefully it'll be balanced because I will mention other vendors that are in the space as I go too. In addition, I have multiple consultancies that won't probably affect my discussions today. So I want to tell you, everyone should aim to have a slide like this. If you don't have a slide like this, you're not doing your job, because one of the things we have tried to do in the pathology informatics community is to make our innovation in the laboratory real through working with the vendor community to bring these products to life. So finally, I've gotten there myself personally, but unfortunately, it puts me in a very biased position when I ever take the stage, so I want to let folks know that I will be very biased in my presentation today, or try to avoid bias in my presentation today, and you decide whether I do it in a balanced way or not. So first of all, I've never spoken at this meeting, and many of the people I really value our relationships for imaging science are here in the room with me: Anant and Metin, Claudia Mello-Tom, some of the faculty in my department, and many other friends that I notice in the audience here. So I really kind of want to do one thing first. How many people here are in pathology of any flavor? Raise your hands. So very few. Okay. How many people are in radiology of any flavor? Okay, expected that. How many are clinicians? Raise your hand. How many are PhD, computer scientists, engineers, or researchers? Raise your hand. Okay, expected that. So, okay, I think I've got the mix. Now, my job isn't to talk a lot about the science, but to talk about all those things together and why this is a phenomenal opportunity and why pathology is going to lead a charge to help improve the science and hopefully play a stronger presence at this meeting. I will do everything I can personally to support this. So let me start a little bit with an introduction to digital pathology, just so you know what digital pathology is and is not. There are numerous places, and we're going to focus on the imaging side of digital pathology, although there are other sides that I will mention in passing. For many years, digital imaging has been used in the gross room, where tissues are brought in from the hospital and various places, processed, and then put into pathology reports, much like patients come into radiology department in what's called the gross room. And it's called the gross room because it's gross, it's bloody, and it's got organs that are resected, and they're in formalin. But images of those organs are very important to understanding the processing of the diseases that those organs capture. They've always been used in microscopic sign-out, although with variable success, and the evolution of digital pathology has largely been driven on trying to figure out how microscopic imaging can play a broader role in the diagnostic workspace for a pathologist. And there are educational support. We want to talk a lot about that. So if people know about telepathology, there are many forms of telepathology. Live video telepathology, called dynamic telepathology, where not only is it video over a dedicated network bandwidth, but also moving the stage of the microscope and viewing the slides like you were at a remote location. There's static telepathology, where snapshots are sent of diseased areas. You don't get the full disease representation. And those can be done on the web as well. all of that telepathology work was done over a decade, decade and a half ago in pathology, although it's still in the mainstay of many pathology departments today. And what's replacing it is something called whole slide imaging. So is whole slide imaging a concept everybody understands? Raise your hand if you don't understand. Okay, so let me give you a little. So what whole slide imaging is, taking the pathology glass slide, that's what we do in the gross room. We take fresh tissue, we fix it into paraffin, and then we put it onto glass slides, much like the film in the film in radiology departments. Our vehicle for diagnostics is a glass slide, at least in the anatomic pathology laboratory. Then that glass slide gets shipped around for use in practice. And that's been the standard in pathology for hundreds of years, back to the days of Virchow. What whole slide imaging aims to do is to take that glass slide and make it a bit of digital information by imaging it in its full diagnostic capability, creating a virtual slide, a digital representation of that slide, and then put it in a virtual microscope, a viewer software on a computer that will allow that glass slide to move around like a bit of digital currency. So when I talk about digital pathology today, I'm really talking about taking anatomic pathology images, moving them into a technical framework that allows them to be shared, distributed, analyzed, much like what happened in radiology with the move from film to completely digital environment in a PAC sense. So we're going to actually talk about pathology PACs today in a large sense. So picture archiving and storage systems for pathology. And with the dropping costs for network storage and CPUs, it's finally possible to do this in pathology. Even a short decade ago, people thought this was totally unscalable, never would be accomplished. And now there are even companies who have leaders that said in public forums that digital pathology would never happen because of that now have digital pathology companies of their own. I'm very proud of that barrier being removed. So this has huge implications for the practice of pathology. And what pathologists do is they take diseased tissues, put them onto glass slides, diagnose them, and essentially, in what we call the 70-70 rule, which I first started talking about a decade and a half ago, the 70-70 rule in pathology is that 70% of all disease diagnoses that are made on you, your families, your children, your relatives, and all patients are based on a pathology diagnosis. And that 70% of all the most usable information, objective information in the medical record, is again pathology diagnostics. So when we talk about the gold standard of medicine, pathology, we're really talking about being the lion's share of diagnostic medicine in terms of objective information. And the glass slide, as well as the laboratory testing, the blood and fluid testing, which we're not going to talk about today, is that gold standard for the practice of diagnostic medicine. It's even going to be more important as we move to theranostic medicine. How many people recognize what personalized medicine is? Raise your hand. Okay, so pathologists will be very critical in personalized medicine. And that's connecting the right patient to the right drug with the right testing to verify the right genomics and the right metabolomics on that patient to make sure you get to the right therapy at the right time. So digital pathology will play a big role in that. And how will whole slide imaging work? This is a very old slide. I'm proud to say that we were talking about this 15 years ago in a grant with TATRAC, which is the Telemedicine and Advanced Technology Research Command, where we were going to create a whole digital library of pathology images to share with networks of pathologists. And we believe now, the march is clearly there, that every pathology department will have a whole slide imager, and will use this in their practice progressively until it gets FDA approved here in the United States for primary diagnostics, which is a matter of a few years away now. So this idea of having a large online archive of digital images, sharing them with pathologists at practice locations and out into their community of the people they serve, including patients, including oncologists, including specialty physicians, is what is happening in pathology departments today. How many people think that's a bunch of hooey? Raise your hands. I'll note that there isn't a single hand up. So as a snapshot, let's take a look at the University of Pittsburgh and say, how has digital pathology gone? And the important message here is we started digital pathology in Pittsburgh back in the early 90s. doing static telepathology or web-based telepathology, then dynamic. We're still doing frozen section telepathology with a dynamic telepathology system. But look at where whole slide imagings come in and how many cases per year we're doing with whole slide. These are only diagnostic cases. These are not educational cases. So as you can see, whole slide imaging is now overwhelming our use of other forms of digital pathology tools in our environment. So whole slide imaging, why is it on the rise? Well, for years we struggled with trying to use snapshots of pathology images for diagnostic purposes. Problem is, pathologists don't like doing that. It's very inefficient for them. And by the way, they don't like that they have to pin down one field and say, this is where the diagnosis is made. Much like in radiology, where it really is the context of the whole case and the area of the lesion and the context of what's behind it. Pathology is very much that way, except maybe that on steroids. Because microscopic imaging probably has a log or two more complexity than flat radiology-based images. Now, I'm sure the radiologist would maybe argue with me on that when it comes to things like CT diagnostics and mammography, etc. But if you look at the storage problem and the compute cycle problem that's behind it, because these are 3-color images and they're at a microscopic resolution that goes to the submicron range versus being in the sub-millimeter range in radiology, you could see that there is a complexity here that warrants meaty, beefy, big and bouncy network storage and computing. And radiology is a perfect partner in all of this, and we have built our whole slide imaging strategies based on radiology because of the excellent work and lessons that have come from the radiology framework. And so getting to whole slides where you can move the entire slide around to use in conferences, for diagnostics, for CAD, etc., has really been the goal of whole slide imaging. Many of you have heard Paul Chang. Paul Chang used to be at the University of Pittsburgh. He was one of the most exciting recruits I ever brought to Pittsburgh to do radiology informatics. He's now keynoting and giving a compelling story about the re-engineering of the workflow related to radiology. Same thing's happening in pathology. Much slower, 2 decades behind, but again, we're going to learn from that re-engineering of the workplace. So distribution of workload, access to experts, commoditization of pathology services are all happening. Our health system has announced 3 international deals to provide whole slide imaging platforms internationally, diagnostics based on whole slide, and expanding our pathology practice today. And unlike the outsourcing of Nighthawk radiology to other countries, guess what? Unlike radiology, pathologists, there are 10 times as many pathologists in the U.S. as there are internationally. And as a result of that, the use of our expertise, diagnostic tools in the U.S. is going to be an important financial driver. So there are practical things like cost recovery from removing couriers and pushing glass slides around. I'll show you some snapshots based on workflow and ethnographic studies we did in Omnics in a few minutes. It has all the same problems radiology had with film libraries and film storage and film distribution. So if you look at the United States and you go to any pathology department today, you see messes like this where there's a mix of cases and incomplete work, stuff that needs to be reviewed again, stuff that's currently reviewed, and it's all based on little trays with 20 glass slides on them that have no way to track them. If you go to an academic archive in pathology departments today, 20% of all the glass slides are missing, the important ones. Sound like radiology a short decade ago? So we have all the same problems, and it's worse in the UK and France and internationally because we actually have semi-automated laboratories in the US, and there's a lot of lack of automation internationally. By the way, how many people are from international venues here? Raise your hands. Wow, over half. I better watch what I say. Okay, so here's my conflict of interest, so you can, if you think this is unfair for me to talk about Omnics, you can shut me off right now. There's a whole group of us in pathology, including my chair of pathology, George Michaelopoulos, who are working directly with the company. We have a rotating pathologist in Omnics on a regular basis. And we have multiple partners, and we're really looking to do digital pathology as a part of the practice of pathology. And I'm proud to say that we have many fine institutions in the U.S. like Stanford and Memorial Sloan Kettering, as well as the University of Pittsburgh and many international locations. UPMC, my health system, has 15 international hospitals and or partnerships. So we are a global concern in Western Pennsylvania. In the studies that Omnics did, we looked at the ethnographic research of how pathologists do their workflows, how they look at images, all the things that were done in radiology to understand how to create workflow tools that will address, both from a software engineering as well as from an image engineering perspective, on how to produce a multi-camera technology that will allow the images to be captured, seamlessly woven together, taking all the diagnostic information with it and doing it in kind of a tiled network, rapid framework to deliver these slides over commodity networks. We also looked at the workflow of pathologists. It's a real mess. This is a real workflow study case at the University of Pittsburgh to look at how many different touches, hops, and users of this anatomic pathology information there is in a hospital system. And clearly, this process is in need of re-engineering. So the purpose of what we have done with, again, Omnics being one of 3 companies really leading in this space, maybe 5 now, Philips, Fantana, Aperio, and Siemens all have products now, as well as GE. Omnics is a UPMC, University of Pittsburgh Medical Center, and GE partnership. All are really focused on getting this this engineering right. And that list are the companies that have the PACS books of work in a dominant play. And we're building their solutions for digital pathology based on what's happening in radiology. And dealing with all the pieces, the archiving, the security, the interface with the histology laboratories where the glass slides are produced, the archive for management, not only for clinical, but for education and research as well. And the idea here is to be comprehensive, scalable, and efficient. So if you haven't seen a whole slide scanner, this is the kind of footprint it has. Not that the Omnics system's any different from the others in terms of footprint, but if you haven't seen a whole slide imager, here's one. The framework is to kind of have an easy touchscreen kind of interface that a technologist in the histology lab can use to load slides and get them imaged, and essentially do that in a framework of a simple workflow with the usual goals of outstanding image quality. Our focus is to scan at about a minute per slide, walk-away use, all types of stains. Pathologists use H&E, hematoxylin and eosin, as their primary currency. About 98% of the slides are done on H&E. There are also slides that have immunohistochemical and special histochemical stains. We want the imager to be able to handle all of those stain types, and essentially have a specific type of scan settings for different types of tissue, like bone, like hematologic slides, like cytologic slides. So this is what a workstation will look like, and the dual screen framework is very much brought out of the radiology community, with dual desktop workstations for the pathologist, where on one side you get the images and the other side you get your LIS information, the information on the laboratory information system, where the text portions of the reports and the framework of the glass slides captured at very low resolution to just give them the feel of slides that a pathologist uses. So digital pathology is to put this whole slide scanning imaging practice into primary diagnostics. Now, the FDA has put this into the highest category of class devices, much like they did with mammography. So it's probably 3 or 4 years still away from this being used routinely as approved FDA instruments across the industry. But there's a lot of telepathology use, consultative use, and informal use in the U.S., but there's already primary diagnostic work going on internationally where they don't have an FDA regulating this type of use, and a lot of the activity is international right now. How many of our international colleagues in the audience know of a digital pathology implementation in their country where it's being used for primary diagnostics? So about 5, 6 hands. Great. So this is, probably not a surprise to you. Digital can do what microscopes, analog microscopes by pathologists, making direct measurements, giving panoramic views. You could never get this kind of a view in a microscope. The information density, because of the tunnel you look down, even in a binocular microscope, would be 1/15th to 1/20th the view size. So to get this kind of view, you'd have to hold the slide up to the light in a pathologist world, where you get these really information-rich images where direct measurements can be happen. This is really upside using this. To this audience, CAD, computer-assisted diagnostics, is red hot in pathology right now. And I'll talk to you why it is. But this platform allows for CAD algorithms to be implemented in a digital workflow and not off to the side on a separate machine where the pathologists don't work, which has been a barrier for using quantitative diagnostics in pathology. So this integrated workstation approach really is there. So what's the vision? We want to decrease average turnaround time for case. That's clearly part of the role here. We want to improve patient safety. We want to do this in a framework of reducing costs. We want to increase pathologist productivity. We want to get rid of a lot of the non-value added parts of the equation, like moving slides around to pathologists via courier and slide trays, etc. Reduce the number of times cases have to be recut because they're lost. Again, 20% of total volume has to be recut in pathology practice. And improving the quality assurance programs. Digital also always helps you improve quality assurance, quality improvement, and quality initiatives. So, digital pathology is drawn heavily from what lessons were learned in digital radiology. Is anyone at a health system where they don't have a PACS system? Raise your hand. Not a single. Oh, two hands. That's actually surprising, because most systems now have adopted it. If I'd asked that question 10 years ago, it would be less than 30%. If I asked that question 20 years ago, it would be 0. That's how quickly we've gone from old film-based radiology to digital radiology as the standard of practice. Pathology's on that curve now. How many places have digital pathology as the standard of practice? No hands, because it's not in the U.S., not surprising. How many places have digital pathology workflows today? Only a couple hands. So we're back where radiology was probably 15 years ago. So all of the things that, I won't bore you with that you know already from the radiology space are there. The kind of labs that will do this initially are high-volume laboratories, distributed regional networks, veterinary pathology, interestingly, where there's a big crunch on access to veterinary pathologists. And it's already happening in pharmacology and in clinical trials research run by pharma and clinical research organizations, or CROs. What kind of things can we learn in pathology from PACS? These are probably dated. On average, there was a 16.2% productivity gain in most PACS implementations, a 57% gain in case volume. So this driver of improved productivity and improved capacity are clearly there. Lean methodologies have been able to be implemented. Study availability increased dramatically. High satisfaction rates are actually reported by most implementations, and actually 3/4 of all PACS initiatives are more cost effective than they were initially projected to be. So I think we'll see the same with what's happening in digital pathology. I think whole slide imaging will also improve the care that we deliver. Split screen comparisons of old and new cases from an archive of digital cases, looking at 2 areas of the same biopsy at once. All the same things digital radiology allows for. Synchronization of lesions of images on tiled images that are cut at different levels. Ensuring the complete viewing of all diagnostic material. There's a dirty little secret in pathology. My residents hated me because I insisted that they review the old pathology cases before they came and signed out the current case. They hated me. On the other hand, at the end of the day, they all came back and thanked me for not only seeing more case value, but kind of living up to our Hippocratic oath of doing all the right things for the patient. because in about 15% of the time, review of the old material dramatically influences what you do in the current case. 15% of the time. On the other hand, when you have to go down to a storage room, pull slides, and find out in 20% of the time they're not there, pretty frustrating. And then if you have to do recuts, pull the old case material, recut it so you can look at it, that's even worse, and you're delaying the interval of care delivery. So it's not surprising. I'm not belittling my pathology colleagues for not doing it, but I insist that we do it. And this was one of the drivers for me personally in making sure these systems got built and architected, even though I've been told for many years that this was stupid, wouldn't happen, technologically infeasible, and too costly. But we're getting there. So integrating the workflow of the pathologist with the electronic medical is another critical part. We're not there yet with that. That's where the most work, in my opinion, has to do. But with what's happening in personalized medicine, which I'll talk about in a little, I think there are going to be many drivers to make pathologists and radiologists work closer together to enable personalized medicine. And then finally, the incorporation of CAD as a real tool and a workbench for the pathologist, to me, is one of the most exciting developments beyond all of this. It'll all be about algorithms in the next decade in pathology. Computer-assisted tools to help the pathologist get more accurate diagnostics. And they won't just be analyzing immunohistochemical staining. They'll be saying, okay, I've got a tough case here. Can you search the archive of images we have? Give me some hints on what this might be for the junior pathologist covering on a Saturday morning on your mom's breast biopsy. That kind of thing would be very invaluable to the practice. So let me take a little bit of a aside to say, okay, I hope by now, have I convinced you that digital pathology is coming and will be an important factor? If not, raise your hand. Good, I don't have any hands up. That's good. Now I'm going to tell you about the second driver. The second driver will be personalized and genomic medicine. And pathology is going to be a major player in the space. So how many people understand and can give me a definition of personalized medicine? Raise your hand. Say, not too many hands. So personalized medicine is confusing. So this is my important figure. So here's what personalized medicine does. This is you, your mom, your dad, your children sitting in this pile here. Today, they get the same diagnosis, they get the same prescription. It's based on population dynamics. Do you know that for cancer, for example, less than 20% of patients will benefit from any of the poisonous therapies we give cancer patients? But everybody gets it because the population statistics say that give them this poison and 20% of them will live longer. Pretty crappy way to run medicine, I'd say. So what we want to do is we want to get to this class of people, pull the people out where the drug is not toxic to them based on their own physiology and is also beneficial to them. And instead of experimenting, most cancer patients get 3 different kinds of drugs before they finally get to the drug that's effective for them. 3 different kinds of drugs or therapies for most solid tumors. That's abysmal. Think about all the wasted cost, much less the wasted time in giving those therapies to cancer patients. So what we want to figure out is how to get to this class where the drug is not toxic and it's beneficial. And we certainly want to separate these out quick where the drug is toxic but not beneficial. That happens about 8 to 10% of the time in all cancer patients. So what personalized medicine aims to do is to use as it applies to pathology, is use theranostics, looking at therapy, looking at the physiology, the genomics, the phenotype of the patient, and getting them into these classes, figuring out which one they are, before we administer population-based therapeutics. So we want to determine whether a treatment's working, too, because, well, let's say we can't figure this out. Maybe it's a choice. So let's use pathology, then, to determine whether the treatment's working and monitor that in the tumors. That's coming. We also want to monitor healthy people, detect early signs of disease so we can prevent them getting into the disease category. That's helpful, too. Produce safer drugs by predicting the potential for adverse effects earlier. And targeted, this is the goal, target groups of people most benefit from a drug while keeping it from those who be harmed. And then a byproduct of this, if we keep track of all this information, will be the production of better therapeutic targets with less toxicity. So personalized medicine will dramatically decrease healthcare costs, get patients to the therapy quicker, and also make sure that the toxicity and mortalities we induce on patients, particularly in cancer, will be much less. So this is going to be a big driver for the implementation of parts of digital pathology. So an example here is in lung cancer. In the past, we used to just look at H&E and make an interpretation to decide what class of cancer it was, and all the patients would get treated. Now, a company out of New Haven, Connecticut, has developed something called Aqua, where they look at multiparametric IHC and have been able to use just this one marker, RM1, to separate out classes of stage 1 non-small cell lung cancer, to stratify them into categories that really separate massively in an ROC curve disease-free survival. Earlier detection, more customization of therapy. Another example from colon cancer. Cytoplasmic MET helps separate two groups of stage 1 and stage 2 colon cancer. So quantitative image analysis algorithms applied to cancer in this framework will allow personalization of therapeutic delivery to patients with cancer, and these are anatomic pathology-based examples. There are dozens of these today. So if you go to the FDA and look for drugs and genes that are linked in oncology that will be targets for digital pathology algorithms, there are already 30 drugs that have genomic or biomarker tests affiliated with them, and there are 26 genes, including the two examples I just gave you, c-KIT, RRM1, and I didn't show you ERCC1, and this is just what FDA approves. Now, you know many institutions have a lot of off-label use of their specialty therapeutics. So one of the things we're going to be doing at the University of Pittsburgh is creating an overall inventory, at least for cancer as a starting point, of the druggable gene targets that will focus our research community on creating both CAD algorithms, but also genetic tests that pathology and pathology informatics will help manage into reality to enable personalized medicine through digital pathology. So this is a slide from Gerhard Schwartz, former president of the CAP, about the future of pathology. And you can see here's healthcare today, where we still have episodic treatment, so everybody gets treated based on population statistics. We're evolving to this transitional period where we will aim to get to personalized healthcare. We're still probably 5 to 10 years away of having uniform implementations of electronic records and genomics and imaging that'll allow personalized healthcare to come into place. But computational pathology, pathology informatics, and medical imaging are going to be key. And you can see digital imaging is starting to broach into this transitional medicine arena. And clinical genomics, which is coming very fast. How many people have heard of next-generation sequencing? Raise your hands. Pay attention to that, because when genomes we're able to do personalized genomes for $1,000, like Life Technology announced with their ion proton machine a couple weeks ago. Doing 3 immunohistochemical tests costs $1,000 today in a pathology laboratory. You can get the whole patient's genome on their cancer for $1,000. Which test do you think is going to get done? Which one will be the discovery arm? Which one will be cost effective when it comes to individual patients and their targets? I think both will feed each other. I don't think IHC will disappear. Quantitative diagnostics will disappear. It'll probably be the delivery arm for implementing personalized genomics. So this continuity here in getting from healthcare today to personalized medicine has a lot of importance on digital, will rely heavily on digital pathology. So genomics and imaging informatics will be key. So tumor diagnostics are increasingly complex. In our aging populations, patients survive with multiple cancers. You know, 20 years ago, patients would get 1.2 cancers in their lifetime, on average. Today, it's 2.8. Why? We're living longer. Therapy is better. Patients are living longer with their cancers. So the financial driver here is significant in that patients will have to go through multiple rounds of these types of diagnostics. Pathology itself needs to evolve from primary diagnostics to these increasingly complex theranostics or personalized medicine, and it's definitely going to require digital pathology as a partner. And unlike clinical pathology, where blood and urine and fluids are analyzed in the pathology departments, they've been automated for a couple decades. Anatomic pathology, where the tissue's done, still done as handicraft and needs to be automated. Whole slide imaging will make this transition occur. And this is going to be important in the evolution of medicine. And if pathology is this gold standard and the 70-70 rule is truly as powerful as it's ever been, then this gold standard that pathology practices will need to evolve, and whole slide is one of the ways that will occur. I want to say a couple things about whole slide. Whole slide is not the end-all, be-all. There are still issues with certain types of specimens that are image-based, like fine needle aspirations that have a three-dimensional nature of it. Most whole slide image implementations today are planar, two-dimensional. There are systems and developments that will take it into three-dimensional space, but we're not there yet. And there are types of imaging, like oil immersion at 100x that hematologists do, that are going to be problematic for some time. But again, these are barriers that I think will get locked down. But I don't want you to think that you could do everything on whole slide imaging. Probably 90%, 95% of the practice of pathology could be handled with whole slide today. But there's probably 5% or more that's there. You know, pathology has a lot to learn, again, from radiology. DICOM in pathology is moving forward. How many people are familiar with DICOM Working Group 26? Good. We're bootstrapping our activities in pathology with what's long been done in radiology. And I think the reason radiology has been so successful, although Paul Chang would not like me saying this, is because of DICOM and the vendor community working with electronic medical records and hospital systems to provide uniform image implementations. We have also developed actors and transactions in an IHE sense. Bruce Beckwith, a partner in pathology informatics, has been pressing forward with pathology and DICOM, and the Working Group 26 has been working with IHE to do take from the lessons of what's happened in the radiology community with IHE and at RNSNA and their demonstration laboratories. We'll be doing the same in pathology moving forward. And just like in radiology, a complete implementation of DICOM in pathology is complex, requires still further refinements. But what's really nice is the vendor community has gotten behind this and has driven it with the academic community and not alone. For years it was the academic community, but now the vendors are actually helping to push it. That's another good sign. And, you know, every one of these things has to have business opportunities. There are large dollars being made now with pharma because most pharma organizations are distributed, doing clinical trials overseas, and have the problem of pushing around large diagnostic images on patients and animals. And so this article from Drug Discovery Today, which was done by Aperio, one of the leader in digital pathology solutions today, Steve Potts from their group, put this article together talking about Aperio-based implementation to enable pharma to do drug discovery and development using whole slide imaging and distributing it in an international network. So I want to lay kudos to the Digital Pathology Association, of which Aperio, Bioimaging, Omnics, and Sunquest have been the core drivers. But corporate members include lots of others like Leica, Olympus, Philips, Ventana. There are others today. They've been a good partner in pushing this forward, particularly the DICOM working group activities. So why are we so slow to adopt this in the U.S.? Well, there's a regulatory environment that has to catch up with this innovation. Well, the good news is the vendor community, our group in Pittsburgh, are in active dialogue with the FDA to push this forward. But the FDA is very conservative, and it'll take probably 3 or 4 years to sort this out before primary diagnostics and whole slide will be approved in the U.S. On the other hand, if you look at anatomic pathology in Canada, where I think the leadership for this is going to be internationally, they have all the problems that whole slide can address. They have unequal access to care. They have big delays. They are undermanned in terms of pathologists. Their care delivery model, rural to urban, hub to spoke, are very inefficient. There's an increasing workload because they, like us, are seeing an increasing aging population, and there's a growing deficit of qualified pathologists. So we, Omnics, and again, turn it off if you think I'm self-broadcasting here, but I think this is a notable academic, clinical, and industrial collaboration, launched a Pathology Innovation Center of Excellence focused on the implementation of whole slide imaging to practice in the country of Canada in Toronto. And PICO, which Pathology Innovation Center of Excellence is called, essentially will be working to stir innovation in algorithm development and implementation of whole slide imaging practices in Canada. Canada has been way ahead of the curve. How many people are from Canada in the audience? So the InfoWay project is probably familiar to all of you. I've been a consultant with the InfoWay project for a number of years, another disclaimer. The purpose of the InfoWay project is digital pathology has been a focus within InfoWay. So they've been already implementing for over 15 years practices in telepathology to help solve their service issues in delivering care across the provinces. And Toronto will be a beacon in that through PICO. One of the demonstration projects is the University Hospital Network out of Toronto, where, again, whole slide imaging will be implemented to support remote pathology locations. There will be no pathologist remotely. It will be done by a histopathologist. Specimens will be processed and will be read in Toronto. So watch for the interesting work coming out of Canada and visit the PICO if you're in Toronto. So with that, there's a number of digital pathology publications, including the one by Liran Pantanowicz, Anil Parwani, Eugene Zetlin, and Claudia Mello-Toms in the medical imaging meeting here today, looking at cytology in virtual slides, Claudia's work in image perception, and our group's work in digital pathology is something to pay attention to, so I'll toot their horns a little bit. We have a number of innovations over the last decade. This is just probably 10% of the articles we have in digital pathology in just the last 5 years. So if you want more PDF, send me an email, and I'll be happy to PDF any of these and provide access to the complete list. So I want to thank you for the participation here. But before I conclude, I'd like to do a little self-promotion here. We do have a pathology informatics meeting. We'll be having its 17th annual conference in Chicago this year. Metin and Anant, who are co-organizers here, have brought their excellent group of folks to participate as a partner in pathology informatics, and I'm very grateful for that. So there is a continued digital pathology, computer science and engineering through CAD presence at the meeting with HEMA, a subgroup that has participated with us. I'm pleased to hear that they're thinking about embedding themselves into this meeting as a home going forward, which is, again, a very bright sign for the space. But if you want to find out more about pathology informatics, or if you have students at any level who you'd like to send to the meeting on our dime, we have travel awards to this meeting, and we fund travel awards to trainees at all levels, fellows, graduate students. We've even had medical students and undergraduates now that have voiced interest early to come to the meeting on our dime. They can apply through the website. We also have a national member organization, API, which acts as the home for all things clinical and academic in pathology informatics. And finally this year, Liran Pantanowicz and Anil Parwani have stood up a new journal, a completely open access journal called the Journal of Pathology Informatics. If you're interested in digital pathology, you must support these three activities: pathology informatics, API, and JPI. These are a great strategic partner with multiple advantages for the people who partner with us. So with that, I will thank the program committee, and I hope I've stimulated some thought about the value of digital pathology. Thank you.